All right, here's the second part of our atrial arrhythmia pre-work for Friday's arrhythmia session in large group. Here we're going to cover atrial flutter and atrial fibrillation. So atrial flutter is a rhythm that has rapid depolarization of a single focus in the atrium, usually at a rate of 250 to 350 beats per minute. So the atrium might be going 250 to 350, which is faster than the ventricle can typically go. So the key feature of atrial flutter is there usually is not one-to-one conduction, meaning that not every atrial flutter wave gets through the ventricle. It might be every other one or every third. Atrial flutter is usually fairly regular, even though it's often fast, depending on how many beats get through. And there's actually atrial contraction because it is a single focus in the atrium, depending where in the atrium that flutter wave occurs. Atrial flutter often arises from the right atrium, and as we'll talk about atrial fib, more often in the left atrium, but either can occur from either atrium. So this would be a typical tracing for atrial flutter, and what you see is you'll see things that look like P waves, or we call flutter waves in this case, and you'll see 2 or 3 of them for every QRS. Now once again, the AB conduction is normal, although not every beat gets through, but the QRS, therefore, is narrow because it's normal AV node into the bundle of His, into the right and left bundle branches. What's going on, though, is the atrium is going very fast, faster than the AV node can accept that signal. It's in its refractory period. So every second, third, or fourth flutter wave actually gets through. And it's usually fairly consistent like that. So the classic appearance is described as a sawtooth or a serrated blade or a saw. Is kind of that characteristic. As I said, usually they're a fairly regular pattern to it, but it could be irregular. They can jump between what we call 2-to-1 conduction to 3-to-1 conduction or 4-to-1 conduction, meaning every second beat gets through, every third beat gets through, every fourth, and it doesn't always have to be the same. It can go back and forth. What you'll notice is that when the rate does change in flutter, it's pretty abrupt. It's going to go from 3-to-1 to 2-to-1. There's going to be a big change in the QRS complex frequency. Okay, you might go from 150 up to 200, or from 100 to 150, just like that. No other rhythm changes so abruptly in its rate with certain changes. Okay, the flutter waves are really what you're looking at. Although we look at the positive, if you want to make it easier to count, look at the negative. The negative deflection is actually how many flutter waves. So here we see 2 negative deflections between the R to R intervals. So we would have 2-to-1 conduction. Atrial flutter with 2-to-1 conduction, okay, here and here, which if our flutter rate is, let's say, 300, our actual ventricular rate is probably 150 in this case. It could be faster. Your flutter rate could be 350, and then you could be at more like 175. So look at the underside if you really want to know if it's 2-to-1 or 3-to-1 conduction. It's not always critical. What you really want to look at is how fast the heart is and that they're in flutter. Flutter, as you notice, is fairly regular. Okay? Here would be someone with 3-to-1 conduction. 1 downwards, 2, 3. So that's 3 flutter waves. Okay, you don't really see the T wave, kind of gets lost. So 3 flutter waves between each QRS, that's 3-to-1 conduction. Okay, so this might be a heart rate of 100, 110, something like that. Okay, as we talked about, sometimes the amount of conduction changes, especially if the AV node is not the healthiest, and sometimes it lets more signals through, other times it's more refractory. You can go from 2-to-1, 3-to-1, or here you have many flutter waves before another QRS, and then you're back to kind of this pattern. So you can see the degree of block, which determines how many flutter waves get through, will affect the R to R intervals. And here we have an irregular R to R interval because the conduction through the AV node is varied. Even though we're at the same flutter rate, it's not consistent how many are getting through. So hopefully that makes sense. Now flutter, because there is atrial contraction, because sometimes the rate might only be 100 or 75, depending on your AV node, it may be tolerated pretty well. Even at 150, that's a little fast, but you do have your atrial conduction, So short term, you might tolerate atrial flutter at 150. Long term, that's probably not the best for you. And certainly if you're up at a rate of, more frequent conduction, 2 to 1 or 1 to 1, then that's really fast and not going to be tolerated. So generally below 40 and above 150 has significant effects on cardiac output. Once again, here's just to give you an example of different flutter rates so you can get an idea. What we really want you to know is that these are flutter waves. Sometimes they look very classic like this. Sometimes they're not quite as obvious. Especially when it's 1 to 1, it can be a little trickier. But once it's 2 to 1 or 3 to 1, certainly it's much easier to see those flutter waves. The other thing you can kind of cheat with a little if you can't, like, well, is that 1, 2, 3 flutter waves, is look at the rate. Here we have 300, 150, 170, and 75. So the rate's a little over 75, which is consistent with 3 to 1 conduction. If you look here, we have 2 waves. We have a heart rate of 300, 150-ish, a little under 150. That's consistent with 2 to 1 conduction, because your atrial rate might be 300, 325, something like that. The other one that you're probably more familiar with is atrial fibrillation. You'll see TV commercials about AFib. You probably have family members or friends you've known that have been in AFib. AFib is the most common atrial rhythm, and in fact, the most common rhythm disturbances we see in this country in patients chronically. Okay? Atrial fibrillation, unlike flutter, is not one focus, but the whole atrium, could be both right and left, or could start in one, is just kind of firing at the same time. So there's no coordinated, really desynchronization or depolarization of the atrium that kind of makes a nice forceful contraction. It's just kind of fluttering or fibrillating. It looks like a bag of worms of the atrium, kind of like when we talk about ventricular fibrillation, which obviously is much more serious when the ventricle doesn't have a single focus and no coordinated contraction. So here with AFib, though, since there's all this electricity kind of going on constantly, it's just randomly getting through the AV node. So as a signal hits the AV node, if the AV node's ready to accept that and transmit it to the ventricle, it goes through. If the next signal comes too soon and the AV node is not ready, then it doesn't go through. So you have a very irregular rhythm with AFib, and what the classic description of atrial fibrillation is an irregularly irregular rhythm. So it's irregular and there's no pattern to that irregularity. So you can see here it's shorter, longer, in between, a little bit longer again. So the rate will vary. Okay. Now on this we kind of extended it out. So this is a fairly slow atrial fibrillation rate. There's a lot of fibrillation waves before the QRS. More commonly in untreated AFib, it's pretty fast. And there's really just kind of random how fast the signals are getting through. But AFib, it's not uncommon to have a ventricular response of 140, 150, which isn't very well tolerated usually long term, or even short term in some patients. And what you'll see is this very wavy baseline. It's not really like a flutter wave. It's just kind of like, I don't really see anything that looks quite like a wave, but it's not flatline. So you're going to look for that for AFib. You're going to look for just a lot of variability in the R-to-R intervals. It's just kind of random. Once again, the QRSs are usually narrow because once the AV node gets a signal and it's ready to accept it, it goes down the normal pathway of the bundle of His in the right and left bundle. So a normal QRS with a variable R-to-R interval and this wavy baseline with no real P waves or flutter waves. Okay? And this is your typical heart rate, how it depolarizes in one spot. It goes in a coordinated fashion, goes to the AV node and on through. Here you just have these random irregular impulses in here. And whenever the AV node's ready to take some electricity, which it's seen all the time, it'll let it through. And that varies. AFib can be paroxysmal, meaning it comes and goes intermittently. That's often what happens at first. It can be persistent, meaning they've gone into it and stayed in it, but you might be able to get them out with medications or electricity to get them back to a sinus rhythm. And then if it's been present for a long term, you can get long-standing persistent AFib, which is much harder to get out of and stay out of. And there are changes that go along with the atrium, and here's showing the left atrium with the pulmonary veins, and how the muscle and the pathways can change over time as you have AFib longer. Here's our little chart that we like to use if you want to look at what changes and what the differences are for AFib. Now, here's pretty typical AFib. You see these fibrillatory waves. There's nothing that really looks like a flutter wave. They're kind of irregular in terms of their spacing and in terms of their size. Unlike flutter waves, which are more regular and definitive, these are just kind of wavy baseline. It's kind of like a ripple in the lake. Okay, so that's what we look like with fib waves. And then you can see the R-to-R interval is variable and just going faster and shorter. In order to get a rate on someone with AFib, you really can't just measure one R-to-R interval. We'll get a rate for that second, but not like it varies. So you really need a longer strip. In a patient, you're going to feel their pulse to get an idea of what their rate is over a whole minute, or 30 seconds and times it by 2. So what you really want to know is what their overall rate is in a minute, and that's what's going to affect cardiac output, not what the rate might be from one beat to the other, because it'll vary. Sometimes, and it just depends on the fibrillatory waves, the chest wall, the EKG leads, how good the tracing is, the connections, you won't really see much of the fibrillatory waves. You almost see kind of a baseline that just kind of oscillates. It's not like bumpy like this. It's just kind of really not flat, but really not a lot of variation, just a little above and below like this. But once again, you're going to see that the rate is not regular. And there's no pattern to the irregularity either. So this is AFib, this is AFib. So you just have to be careful when you're looking at EKGs. So why is AFib bad? Well, high ventricular rate, so what we call atrial fibrillation with rapid ventricular response, can result in decreased diastolic time, decreased stroke volume, okay? And remember, the coronary is also perfused during diastole, so if someone has underlying coronary disease, AFib could bring out signs of ischemia. Okay? It's also going to lose the atrial kick. It's going to have some other issues, so it tends to increase the filling pressures and have some left ventricular dysfunction. So maybe someone who's kind of normally okay and goes in AFib now has some elevated left-sided pressures because of that, and now they've gone into some mild congestive heart failure or more significant congestive heart failure. So people may come in because they went into AFib, and now suddenly they've developed symptoms. And they may not complain of their palpitations. They may complain of shortness of breath and congestive symptoms. You get the EKG and see they've gone into AFib and it's new. That's an important finding. The other thing besides the rapid rate with AFib, and as I said, when the atrium's not contracting well, it's going to have a higher pressure. The ventricle's not going to work as well. It might have a higher volume and pressure, backs up to the lungs, but you're also losing your atrial kick. Now, for most of us at rest, that's not that important. But when we exercise, it is. So someone who goes into AFib might be symptomatic when I can't walk as much anymore. I'm getting shorter breath when I try and walk 2 blocks where before I was walking fine. At rest, I'm okay. Or they may have a heart that's not normal and relies on an atrial kick. So think about who might that be. Let's say they have long-standing hypertension that hasn't been very well treated, or something like aortic valve stenosis. So they have a very thick left ventricle that takes more pressure to fill it during diastole, remember? And the atrial kick is that last part of diastole that shoves that last amount of blood into that ventricle. If you don't have that, they may have underfilling of that ventricle, hence their stroke volume, hence their cardiac output may drop. Okay, so loss of atrial kick can decrease cardiac output by up to 25%. And then the other thing is, if you think about what's happening inside that atrium, we talk about Burkow's triad in terms of what causes blood to clot, whether it's in a vein in your leg or inside your heart. One of those is stagnation. Blood that is stagnating or not moving properly, when the atrium is not doing this, it's just sitting there quivering, there's going to be blood that's sticking along the sides of the wall, and when it stagnates there, it's more likely it can clot. So the biggest life-threatening risk also with AFib is development of clot in the left atrium, which then embolize, and of course that can cause a stroke. It can go to the intestine, it can go to the leg, but thromboembolic problems with AFib is very important, and most of the commercials you see on TV, a lot of them about AFib are about anticoagulations that's used in patients in AFib. And so I kind of already covered what other concerns you have to think of, but we'll go over this a little more in class, thinking about what the atrium is or really is not doing. Okay. Final slide, here's atrial fibrillation. Sorry, it's a little bit blurry. Here's atrial flutter. You should be able to tell those difference. And then as we already talked about, multifocal atrial tachycardia, which has P waves that keep varying, and there is an irregular rhythm because there's different spots in the atrium are firing. So you have P waves, but it's not regular and they don't look the same, so it's not flutter. And you have P waves, it's irregular, but it's not AFib because there's P waves, even though they're both irregular. Okay. All right, thank you.